I'm here today at State of the Heart Cardiology with Dr. John Osborne, and we're going to now see what literally it looks like when you take a person's heart, bring that out, and look at it in three-dimensional forms and see what's going on in the heart. Dr. Osborne's also going to share with us the other things that he can see on these very special images that's called a CTA, or a CT angiogram. Dr. Osborne, thank you.
Let me take you through this, Scott. When we take these images, we take about 3,000 slices in about 10 seconds. So it's a very rapid-fire, high-speed CAT scanner. And with this, it then allows us to take this data and, as I tell my patients, it's kind of a virtual autopsy. So let me take you through that right now.
You know, before we jump into that, perhaps it'd be good to talk about the process of getting the test for one moment. I've had 2 of them, so I've got a little experience. And for what you're about to show us, it really isn't uncomfortable at all to get this information.
It's done with a very fancy, sophisticated kind of CAT scanner. It's just a big donut. It's not like an MRI where you're going in a big dark tube. Takes about 10 minutes on the table generally, and to actually take the pictures is about 10 seconds.
That's amazing. So,
and that's it.
My experience with it was I came in, they put a little IV in, they put some leads on my heart. I laid down, I had my hands above my head. They said, take a deep breath, let it out, take a deep breath, let it out, take a deep breath, let it out. You can now get up and go.
That was it.
Amazing.
That's
so
it.
This is what we're going to see from that.
So as we take all those slices, we can then reconstruct this data. This is the raw data we look at first. Let me just orient you to what is on these pictures. This image here is the same data set, but now arrayed slightly differently. This is your heart in the middle. I call this the chest x-ray view. The heart in the middle. This is right lung. This is left lung. Down here would be your stomach, and there's your liver. The red bar shown here is actually that individual slice taken at that level. So I can go to the top of that slice here, or I can go to the bottom.
Okay, so this is looking at me from, like you're standing in front of, like we're standing in front of the person and looking toward him that way. This is like we're down at their feet,
right,
and you're taking a credit card level slice of them,
right,
and we're looking at them going up and down
slice
toward
like
their
this.
head.
That's
so
correct.
This is their neck.
Right.
This is their feet.
You got it.
And this is what we're looking at from the side,
exactly,
or from the bottom. Sorry.
Exactly.
Yeah.
And so what we're seeing here, breastbone here, spine, right lung, left lung, heart is in the middle. First of all, we're going to look at the lungs. We do this because we find on average about one person as we're scanning the heart to get information about atherosclerosis or plaque, about one person per month will happen to find an incidentally found, small, early, curable lung cancer.
Wow. Because the
you get all this additional data.
Yeah, the dogma
right.
on lung cancers, we
you
never catch it early enough.
Right.
So this is actually going to catch it early enough, possibly.
I just got a call yesterday. We had a fellow who, we did his heart. He was having chest pain. His heart was perfectly normal. But he had been a smoker, and he had a lung cancer. We diagnosed. Good news is I got a call from his doctor yesterday, and I mean, this is tragic. I mean, I was really worried about the guy. Get the call yesterday from his doctor. It was an early stage 1A lung cancer. They took it out. He does need chemotherapy. He does need radiation. Complete cure. He's done. And had it not been for the scan, not only did we find that his heart was fine, but we also found this lung cancer that would have only shown up several years down the road when it's incurable and would have died from it.
Wow, what a deal.
So let's look at the lungs here. So we're looking at the lungs. Right lung here, left lung here. Now this isn't. This is a different person. This is not you. But here we can see there's some scarring down here of the lung. Not unusual or atypical.
So the scarring appears as white. If the lung is usually black,
right,
and if you get this scarring right in here, you're looking at the white, and that tells you that it's thicker tissue.
Yeah, right.
Okay.
Not terribly unusual. No cancers, tumors, masses. We can detect emphysema here, even the earliest amounts of emphysema, pneumonias, fluid on the lungs. So we're looking for all that in the lung windows, as we call it.
And you didn't talk about this box right here, but I'm actually seeing, as you're doing here, this is looking at the person from the side.
We're slicing you right down the middle.
Middle. Okay. So and this what we're seeing here is what we're seeing here.
Absolutely.
And what we're seeing here. This is the same right there.
All the same data set.
Got it.
Okay. Because when you do the scan, we actually get volumetric three-dimensional data.
Yeah.
And I'll show you what it looks like
You've used the term virtual autopsy. That's what you mean.
This is the virtual autopsy.
It's like they're seeing inside of you without
I tell
you
people,
dying.
what does this really mean? It's the same as if I put you in a deep freeze, took a chainsaw, cut you here, took a big pineapple core, took a big chunk out of you. That's what we're exploring right now.
I like the virtual autopsy word better. That was
we'll
a bit
keep with
graphic.
that.
Yeah. All right.
So lungs look fine. No tumors, cancers, masses, pneumonias, emphysema, etc. We're going to look here at the aorta. So John Ritter, the actor, died of an aortic aneurysm. Typically, the first symptom of an aortic aneurysm or enlargement of the aorta is when it bursts and kills you. That's the first symptom. So here, incidentally, we can also look at that. So significant reassurance and peace of mind.
This round thing
that
we're
big
seeing
round
right here
thing.
and here, this is it. So let's go to the side
So
picture
on the side
here.
view, you can see it coming up out of the heart here. This is the
so
heart.
this is it right here?
Starting right here, heading up. It's going to loop up and then come down and head back by the spine down to the belly.
Oh, that's so neat.
So that's the aorta. In fact, we can actually enlarge that view here. And that's what we're looking at here. So now I'm slicing you left to right.
Go back. Right there it is, coming down the back. And then right here it is going up. So there's the C,
there it is.
if you will.
In fact, while we're here, we can also look at the this is your esophagus right here, so we can look at that, make sure that's okay. Make
And
sure
the
there's
esophagus, for those who might not know that term,
is the food pipe, right?
Food pipe, yeah.
That's where food comes
and
down.
it comes from the mouth, goes down, and it goes through the diaphragm, right? This is the liver, and that's the heart, right?
Yep.
So there's the diaphragm, and it's going to go through that. And a hiatal hernia is when part of the stomach pooches up above the diaphragm.
And that can cause bloating, gas, reflux, lots of things. And what's interesting is the same nerves that go to the stomach and the esophagus, the food pipe, also go to the heart. Yep. So many people can have reflux and heartburn, and it can feel just like a heart attack.
Yep.
That won't kill you. But there are people that have heart disease or angina or chest pain that's actually due to the heart, and they think it's reflux, and that can kill you if you think it's heartburn.
Can you turn those little windows back on here?
Yep.
So what we're looking at right here is the line between the abdomen and the chest, right? So this is the line, and then the if you go back to the little picture over here again just a second ago, is we're seeing the tube come down here. That is the pipe right where it goes through. So as what you just said to me is that if this hurts or if this hurts, because that's the heart right there.
Yeah.
Right? So
it's
laying against each other.
You can't tell.
So when people think they have indigestion, they could have heart pain, and when they have heart pain, they think they could have indigestion. You can't tell.
The indigestion won't kill you, but heart pain thought to be indigestion can be lethal.
I've never seen a picture in my entire life that shows me how close those are together the way this does. That's really special.
So we look at the aorta, so no aortic aneurysm, et cetera. We look at the esophagus. We also look at, we're going to look at the pulmonary arteries. So the pulmonary arteries coming out of the right side of the heart, these are the arteries that send all the blood to the lungs. This is important because people can get blood clots or pulmonary embolism that can occur in the lungs that, again, is a very worrisome kind of issue. And as I tell people, frankly, what we're doing here is many times we're doing this for people who have chest pain. And our concern is this lethal, life-threatening chest pain or not? And as I tell people, in the big picture, there's only two kinds of chest pain. The stuff that kills you and everything else. And the stuff that kills you is basically three things. Aortic aneurysm, this enlargement here, which this patient doesn't have.
This is a great view, by the way, right here. You can see the aorta there.
Yep.
The red line, we're seeing it right here.
Yep.
Got it. Cool.
Coronary artery disease, which we're going to look at in a moment, and then pulmonary embolism. If you don't have one of those three causes of chest pain, whatever that chest pain is, won't kill you.
Fascinating.
And that's a very important distinction.
For the sake of understanding, you've gone from the aorta to the pulmonary arteries. The blood comes in the superior vena cava and the inferior vena cava and flows into the right side of the heart. Then it goes from the right side of the heart to the lungs, and that's the pulmonary arteries. So there you go. Oh, that's a beautiful view right there where you can see it tree out.
Right.
Okay. And then it goes back from the lungs into the heart, and then...
Here's the oxygenated blood, shown in the brighter color, flowing back from the lungs.
And then it goes through the heart.
Through some of these valves,
Yep.
into the main pumping chamber. This is the left ventricle, the main pumping chamber of the heart. And from here, it's going to pass out this valve, out of the aorta, out to the rest of the body.
So then it goes out to the aorta. So you can see the whole flow of blood as it comes to
the whole
back
thing.
to that. That's so neat.
And then lastly, we always like to look at this. We're going to take a peek at the spine, and this is someone that has a lot of arthritis here in the spine. You can see all this stuff right here is all arthritis along that part of the spine.
That makes me want to sit up straight. Okay, so how old a person are we looking at here?
This gentleman is actually 72. So
not bad for 72. I mean, here's another view of it that's nice. You can see the little square vertebrae.
Yep.
And then here it is in the back. We're looking at it, and then here it is. We're looking through the center of it.
Mm-hmm.
Oh, that is just really, really.
And again,
have you ever found a bone tumor or a bone?
Oh yeah.
Really?
Yep. And people can have chest pain and back pain because of problems in the spine, arthritis, tumors in the bone, things like that. So again, we can evaluate and look at that along the way. So there's lots of gravy that we get in addition to this. Let me show you one little interesting thing here in this gentleman. Is that as we're looking at the aorta, this is looking at it from the side. This slices from the side.
So here it is coming out of the heart.
Aorta coming up.
Okay.
Here actually, as you talk about the circulation, here's the superior vena cava here, draining into the heart.
Ah.
And then down here is the inferior vena cava.
Oh, wow.
But let me just show you, in the aorta here, see this stuff right here?
Uh-huh, the little white speck.
That little white stuff here, see that right there? See this right here?
Oh, yeah.
That's plaque. That is atherosclerosis. That's plaque. Now, in the aorta is a 30 millimeter vessel.
30 millimeter being about as big around as a quarter or a half dollar?
Or actually about a half dollar.
Okay.
So 1 or 2 millimeter plaque in the aorta in a 30 millimeter vessel,
not a big deal,
you.
except
that is a marker.
Okay.
Because the aorta is an artery, just like the arteries in our heart. If this artery has plaque, already that heightens my suspicion that you could have plaque in these smaller vessels. Now, a 1 or 2 millimeter plaque in a 2, 3, or 4 millimeter vessel in the heart is an entirely different scenario.
So have you ever diagnosed an aneurysm?
Oh, all the time. Oh, all the time.
Really?
Oh, yeah.
And do you usually see those around plaques? Is there a relationship between the plaque and the aneurysm in the pictures you see?
There are different kinds of aneurysms, but yeah, it can be related to the plaque. Sometimes it's related to high blood pressure can cause it. But we'll see that. You're just not going to miss it here.
Wow.
And our goal is pick it up early so you can treat it early, take care of it. So ideally, I've got lots of patients that had actually been referred for surgery to fix this, but if you detect it early, we can actually do some things and treat this with medications and such, and they never even have to go in and fix these aneurysms.
Wow, well, particularly in the chest, those are a real booger to go get, aren't they?
Yeah.
So if you can catch it early and keep it from growing, it's a much better deal.
And again, if you show up with a symptom of aneurysm, usually that's when you're dead.
Yeah.
Yeah, you usually don't survive
That's
that.
the tell my wife I loved her punk.
Yeah. So after that, we're going to take all this information, these 3,000 slices, and then we're going to take this and now reorient this so we can look at the heart.
Okay, so what we've done so far, just to summarize, is we've gotten the scan, took all of 10 minutes. We've looked at the lining of the lungs. We've looked at the lungs. We've looked at the backbone. We've looked at the esophagus. We've looked at the vessels coming out and going into the heart. All of that in a matter of, well, if we hadn't been chatting, you could have done that in 6 or 7 minutes.
Yes.
Now you're going to just take us on a tour of the heart.
Now we're going to focus like a laser beam on the heart.
Cool.
And we're going to look at the blood vessels and the coronary arteries. And right here is actually looking at your heart.
Ooh.
So there's your heart. As I tell my patients, if I knocked you out, pulled your heart out of the chest, this is exactly what it would look like.
This is the Aztec maneuver, huh?
This is the Aztec maneuver.
Pull it out,
Yep.
stick it on the screen.
Well, I tell them, if I pulled it out, washed off the blood, that's what it looked like.
Well,
Okay?
thank you for not doing that.
I wouldn't do that to you. So this is the heart, and these structures right here, the coronary arteries. We're going to go through each one of those. I'll take you through that. And this is the back of the heart. This structure right here is the left ventricle. This is the right ventricle. This is the pulmonary artery heading off the lungs. And this is that big aorta that we were looking at before that comes right out of the heart, sending all the oxygenated blood off to the rest of the body. And that's the superior vena cava and the inferior vena cava, the arteries the veins that basically lead the blood back to the heart.
Wow.
So there's your heart.
So when somebody listens, orient the heart the way it is in the chest.
It's basically oriented just about like that.
So when a doctor listens to your heart, he often starts up at the top left and then right, then left, then down. So he's going from here to here to here to here is where they're usually listening. Fascinating.
That's correct.
Got it.
So we're going to shrink this image here. Now what we're going to do is we're going to look at each one of the blood vessels, and I'll show you how we're going to do that. And this is a pretty amazing process as well. As I click on this particular vessel, we call this the LAD. Now, we joke a minute, lighthearted cardiologists call this the widowmaker, just because it's a pretty important blood vessel, supplies a lot of the blood flow to the heart. This is the LAD that comes down the front part of the heart. As I click on that vessel here, I'm going to take that three-dimensional image, think of this as the globe view, and convert this to this two-dimensional map of that same vessel.
to say what you just said in a different way, if a person has a heart attack out here, that's what some people call a minor heart attack.
Right.
If it's a heart attack up here, it's a major heart
The
attack.
further upstream, the bigger the river, the bigger the part of the river, the more trouble you're in. Okay? This is the Mississippi. As it gets down here, you're into the Monongahela in Ohio. Okay?
Now, so this is here.
Yes.
And this is here.
You got it.
And what is that?
Well, that's plaque. And let me show you how we're going to further look at this plaque. Now, appreciate, the heart is a three-dimensional object. We've got a two-dimensional map here. But what happens is, with the magic of computers, I can take that data. We've got this volumetric, inherently three-dimensional data set. And as I turn your heart here, I can turn and spin that blood vessel here 360 degrees. So I can look at that blood vessel from any conceivable angle. I can spin you 360 degrees, so I can look at you from, again, any way. I can also spin you on your head. I can sit you upright. So we can look at that vessel, again, in a very almost microscopic, very comprehensive way. We're not going to miss anything here. And that's why I tell people, when we do this, if there is problems, we'll see it. If there is not a problem, there is not a problem.
Wow.
In fact, just to compare this to other techniques that we've used to evaluate the heart, this shows a cross-section of the blood vessels, and I'll show you that here in a moment, how we also can cross-section these vessels. This is a normal vessel, normal channel, we call it the lumen, and the normal wall. Plaque, early plaque, baby plaque, always starts out here in the wall. You'll see that here in a moment. And the whole vessel early on actually literally expands and gets bigger in order to accommodate that plaque. Now, if that process continues, then ultimately that vessel can no longer expand and we begin to narrow that channel. But even at this point, we still don't have symptoms, no chest pain, no angina, normal stress test. It takes about a 70% blockage or narrowing before we begin to hit to the point where we begin to have symptoms or chest pain or angina. So when people need balloons and stents and bypass surgery or flunk their stress test or have angina or chest pain, they don't have a little disease. They've got a lot of disease.
And when a person has a heart attack, is this when the heart attack occurs here, or does the heart attack occur back up here?
Well, this sets you up for the heart attack, but this is the heart attack right here. And many times you have plaques that are actually sort of between these two plaques. No blockage, no obstruction, no symptoms, normal stress test. But what happens is the shoulders of the plaque right here are really mushy and unstable and tend to break up and flake and break down. And what occurs is we go from a channel that's big enough to supply enough blood flow to the muscle to suddenly, when that ruptures or breaks, suddenly we form a blood clot here, and now suddenly we go from no symptoms, no chest pain, to a completely blocked blood vessel. And if that's a blood vessel such as the big Mississippi here, that translates into a big heart attack, or worse yet, sudden cardiac death.
So what I hear you saying then is that you can't tell from like a stress test if you have disease,
right,
or if that disease is at a point where it could rupture and kill you.
Right, absolutely.
You have to look at this level
You got to
of data.
you got to look at the blood vessels. Okay?
I got it.
So here's that blood vessel now, and again, you can see this is clearly not normal. This white stuff is hard plaque, but there's different kinds of plaque. With this tool, we can not only see the narrowing, the channel, we can see out into the wall of the blood vessel, but we can also characterize the plaque, because there's some plaques that are much worse versus other plaques that are relatively more benign. This plaque right here, that calcified plaque, is a relatively benign plaque. It's a plaque. It can cause narrowing, but it's not going to tend to rupture or break down.
Well, this is the aorta right there, right?
Yep.
I mean, it sure does seem like it's way upstream toward the Mississippi.
Absolutely.
Is that okay?
This is a bad area.
Okay.
This is a really bad area. Now, note that the first time we did this test on this gentleman here, he'd had a normal stress test 6 months beforehand. Did not pick this up. In fact, he exercises every day, eats right, he never smoked, he has no diabetes, he has a little bit of high blood pressure, but his blood pressure is perfectly well controlled, and again, no symptoms. But he's got a family history, and he also has siblings who have already had balloons and stents and heart attacks.
So this is the kind of guy, if this was a 40-year-old, that if that ruptured, he's out on the golf course, swings, says
Typically,
4,
that's
grabs
it.
his chest, and he's gone.
That's it.
So it sure would be nice if at 39 we could get him in here and get this done.
No question. And again, this plaque has been grown there for decades.
That's not new.
That's not new. That didn't start last month, last week, last year.
Wow.
So here we can actually zoom up on that plaque here. So there's a close-up view of that plaque. And we can kind of almost do a analysis of the plaque, almost like we do in a pathology lab, right? And here we can look at the character of the plaque. There's calcium or hard plaque here. There's lipid-rich plaque here. This is the cholesterol-rich plaque. This is the nasty, mushy, unstable kind of plaque. And this white little dot right here is actually a necrotic core. So these are all the signs of a plaque that is about to rupture. This is a pimple that's about to rupture.
So John, let's go through the natural history of a plaque using this, because you can just use this diagram right here and see it.
Right. Every time you see this, it tells you.
Normal vessel.
Right.
Then cholesterol, LDL-C, which is the amount of cholesterol you've got, or LDL-P, which is the particles. The more particles you have, the more likely the particles are to get in the wall. And when they get in the wall, it forms this black mush. Is that what you're saying?
Yep.
Then what happens next? Does it get necrotic, or does it get calcific?
Well,
or?
if one could look at this over a period of time, this is older plaque. These are like tree rings. This is plaque that has been there longer than here. So this is where the plaque is beginning to. This is the newly formed plaque.
Oh,
this is
like
older,
spreading,
more mature plaque. Right.
Okay.
I think of it kind of as a volcano. This is the part of the volcano where you got hard lava. It's rock solid. Say it's already erupted. But here is where you got lava and magma. Okay. This is the stuff that's really going to tend to kill you. And we're actually seeing the natural history, the biology expressed just in this. This individual.
And the big message to the people who are seeing this is, if you go back, you can literally take this, shrink it, stabilize it, and keep it from rupture.
No question.
We have the technology.
That's what we do.
But you got to know it's there.
Absolutely, because you don't know that you have it to be able to use those technologies and approaches. So again, we can turn, spin, rotate that blood vessel. We can also then take that vessel here, and now with the magic of computers in this window, we're basically straightening that vessel out. And what we can do is this allows me the ability to turn and spin, rotate around that blood vessel, so you can see that plaque here. And you can actually see, it's a little subtle here, but you can actually see, and I'm going to zoom up on that blood vessel, this gives me the cross-section anywhere along this blood vessel. So in fact, what I can do with this blood vessel is I can literally, as we might in a microscopy, histopathology lab or autopsy lab, we'd take that artery post-mortem, right, and we'd chop it up and we'd see where there's plaque. Well, we can now do that before that occurs
before you die. So said in English, if you were a stiff, we could take you, pull that artery out, lay it down, chop it up in little pieces, and
which
look
would tell
at
us
it.
the answer, but a little too late.
Yeah, got it.
So here, this is the cross-section here, and you can see now we're beginning to hit plaque.
Yeah.
And note, but that plaque is out here in the wall.
So is this dark spot right here early plaque, and the white stuff is old plaque?
It's a mixture of some plaque. But note the channel here, particularly at this location, as we cut directly through that blood vessel, that's the cross-section here. These are the cross-sections 1 and 2 millimeters downstream, and the cross-sections 1 and 2 millimeters upstream. Looks just like that. So what we're seeing is just like our model. This is plaque that's grown outward. There's no blockage, there's no obstruction, but there's a significant amount of plaque there. But also we can characterize the plaque at that location. It's a calcified plaque that's relatively stable. It's more like cement. As we move further down this blood vessel, we leave the calcified plaque, and now we're heading into the new plaque. And you can see here, what's amazing, this white is the channel or the lumen. All this stuff out here, this gray stuff, is how big the vessel used to be, and all of that is lipid or cholesterol.
Wow.
So this really gives us an incredible view of
You have some way of making this color look that color. How do you do that? No, making this look that color is what I'm trying to say.
Oh, we can also turn on this window. This is what we call, we use a tool in the cath lab, an invasive tool, we don't have to do that anymore, called virtual IVUS. So what this means is we can take all this data and then convert it to this image here, where we can basically, if we were to translate all this to a three-dimensional view, we were to shrink ourselves and do the fantastic voyage in our little microscopic submarine down the coronary artery, that's what it would look like. Okay,
so go slowly here for one. Could you go back to the beginning, and let's go slowly to make sure that people understand what you're saying. You have vascular biology, which is the outside of this, and luminology, which is the inside.
Right.
So the fantastic voyage is, whereas if you go to a cath lab and you have a cath done, all they get to look at is what's inside the circle.
That's all I can see.
But what you can look at with your CTA is the circle and the donut.
Right. So when we used to do angiograms or heart catheterizations, the limitation is, particularly because of how the plaque grows, if I did an angiogram on this blood vessel and this one, with plaque out here in the wall, did an angiogram on that blood vessel and that blood vessel,
they look the same.
They're exactly the same. I couldn't tell, and I'd say they're both normal. In fact, when we used to angiograms, I would always carefully say, because we knew that this was the case, that it is angiographically normal, which means the channels are okay, but I have no idea if you got plaque like that out here. By the time you get to here, most of the times we'll detect that on an angiogram as long as we have sufficient views. And down here is when we flunk our stress test.
Yeah.
And have chest pain.
Got it.
And here you can see the channel, and then this is all the plaque out here.
Okay, so let's just focus on the circle, and then take us on the virtual donut tour here.
And then here, as we get into normal vessel, you can see that the wall is nice and thin, and there's the channel or the lumen.
Wow.
Now, the other thing that we can see here, and I'm going to turn this off here for a moment, is that this, remember that this whole blood vessel literally expands and gets bigger, and that's what we're seeing here. So we're actually seeing an expansion of that plaque going outward at this point. That's why this person has no symptoms, no chest pain, and had a normal stress test. In fact, the first time we met this gentleman, we did the first scan, this plaque was much worse.
So you've actually regressed the plaque. You've made the plaque better.
This is now 18 months later. He'd had a normal stress test 6 months before he had the scan, and he felt, I'm great, I'm in perfect health, I have no issues. We did this, and we both realized he's got an issue. We then aggressively treated him, and what we're seeing now, 18 months later, with optimal numbers and blood pressure and cholesterol, et cetera, we're literally watching this plaque reverse. The first study we did, this was about a 60 or 70% blockage. Now we're down about 40% in the span of 18 months. And appreciate this thing's been growing there for decades.
So why would you not take that person to the cath lab and put a stent in or
Well, you know, we know now that in ballooning things and stenting things and opening things up and bypassing things is really good to treat symptoms when you got a severe blockage. At this point, we caught it before he had a severe blockage, and he doesn't need us to do invasive procedures or put in $3,000 worth of metal to open and prop open that blood vessel, because it's still adequate to deliver enough blood flow. What we need to do, because when we balloon things and stent things and bypass these vessels, it doesn't treat the condition, it doesn't treat the disease, it doesn't treat atherosclerosis or plaque. It pushes things off the side or bypasses around it. So for this gentleman, and he's actually had 2 stress tests now, because of the first test, we were really concerned. We did another stress test, making sure there was absolutely no evidence that there was a restriction of blood flow, and there was not. He had 2 normal stress tests. When we can, with that understanding, opening that blood vessel would not buy him any benefit, but treating this aggressively would actually treat the plaque, and we can actually help to reverse it.
And what did you use to treat him?
So we actually used a combination of beyond diet and exercise, an aspirin a day. We gave him some fish oil or omega-3 fatty acids, and we also gave him a statin to lower the bad cholesterol, because his bad cholesterol was still high, and his HDL, the good cholesterol, was low, so we actually gave him niacin, or a pharmacologic preparation called niaspan.
Wow.
And with that, his numbers changed dramatically, and he went from plaque forming to plaque regressing.
Amazing. Now, what's the chance that that still breaks open and he has a heart attack?
You know, when we begin to see this process and see these plaques regress like that falls dramatically.
So it's kind of, it's like there's pressure inside of it that's building it,
right.
And then the second you turn that around, it's like,
right.
It starts to feel better.
Yep.
Got it.
So this is how we actually look at all the blood vessels. We're just focusing on this one blood vessel, but we go through all the different blood vessels. There's little branches of this major blood vessel here. There's 3 major blood vessels that go to the heart, and we look at all of those. Now, he was fortunate that this disease tends to be spotty. It tends to be sort of isolated in different vessels and different spotty areas. But the rest of his vessels look pretty good. In this blood vessel in the back part of the heart, you can see he does have another, exactly. See, you're good.
I'm getting there.
Yeah. So here, he does have some other plaque here. Again, this is stuff that is in the wall. You can see here it's growing outward. If I did an angiogram on this blood vessel, couldn't see it.
Nope.
Couldn't even see it. I wouldn't be able to say, gosh, do you have plaque or not?
That's amazing.
And then here, again, you can see literally the vessel's gotten bigger. He's got some calcified plaque here. This is not the kind of plaque I'm worried about. And as we treat the plaque elsewhere, all the plaque everywhere, both in the heart, in fact, everywhere else in the body will get better too.
Wow.
So fortunately for him, the real hot spot is that area right here.
And it's one you're treating and following. And
yep.
So will you do another one of these scans once a year to make sure it keeps getting small?
It depends upon the burden of the plaque, how much cholesterol-rich plaque they have, and all that. In him, I was really worried both because of the size of this vessel, the location, how much cholesterol plaque he had there, all the characteristics of a vulnerable plaque, the kind that ruptures. In him, we kind of did more frequent repeat scans.
So, and as far as
depends upon the patient.
There was actually an article in the paper a couple of weeks ago that said, "Oh, you're exposing people to too much radiation with a test like this." What are your thoughts on something?
Well, it's kind of interesting. If just sitting here in the Dallas-Fort Worth Metroplex, just in any given year, from background radiation from the sun, isotopes that are all around us, just everyday life, we're going to get 3 millisieverts, as we call it, worth of radiation, doing nothing at all. When we do these scans, we're going to get roughly maybe 9 to 12, okay? But interestingly, when we look at other techniques to understand the heart and get an idea what's going on, with like stress testing, we can give up to 30 millisieverts.
Like nuclear stress testing.
Nuclear stress testing. Right. And if we do a heart catheterization, we're going to get the same amount of radiation, but dramatically less information.
Got it.
And so, vis-a-vis the fact that this is a condition that kills half of us, there is radiation exposure, but the risk of that radiation is so minuscule versus dramatic information to help us to understand whether you got the disease or not and detect it early. So we also get functional information here. We can take all this data, because we get not just 3-dimensional data, but actually 4-dimensional data. And here what I'm doing is I'm cutting the heart up into 4 different slices, and we can watch the heart beat inside the chest. So we can look at all the walls of the heart. We can look at the left ventricle. This is the mitral valve here. We can enlarge any of these. This is the mitral valve, one of the heart valves. We can watch that open and close. We can make sure that there's been no heart attack or heart damage. I can look around the heart, make sure there's no inflammation around the heart or in the pericardium. This view here shows us the aortic valve opening and closing, so it's all dynamic. This view here, what we're looking at is we can literally take the heart like a loaf of bread, and I'm chopping the heart up. This is the very tip of the heart. This is the left ventricle here, the right ventricle here, and I'm basically chopping the heart up like a loaf of bread so we can look at all the different parts of the heart muscle to make sure there's no evidence of any heart attacks, heart damage, or anything like that. This structure right here is actually the mitral valve. We're sitting below the mitral valve, and we can watch that mitral valve open and close.
Absolutely amazing.
We also can calculate all the sizes of the heart, the dimensions of the heart. We can calculate how much blood the heart pumps per beat and per minute. We can calculate how much the heart weighs. This is how much the blood pumps per beat and per minute. We can calculate the efficiency of the heart, the size of the volume of the heart, and also the weight of the heart. We all do that in the 10 seconds.
So if someone had heart failure,
we'd actually see the heart enlarge, and you can measure that. And we'd also, in people who've had it, we can also measure it improving too. We can also see evidence of old heart attacks and scars. We can also cut the heart up into 20 pieces and measure the thickness of the heart muscle throughout the whole heart. Because if it's abnormally thin or thick, that gives us important information about the heart. This is showing all of those segments when they're squeezing, and this just shows all those segments are thickening normally, showing no evidence of any prior heart attack or heart damage.
Amazing.
Remember, we get 3-dimensional volumetric information about the heart, so we can also, because we have the data and we're going to look at it, we can also look inside the heart as well. So we can look at the valves. This is the aortic valve. That's one of the major valves of the heart, so we can make sure the heart valves are normal as well.
Amazing.
And what I'm going to do is we're going to look at that valve. This is the aortic valve right here. It has 3 leaflets or cusps, 1, 2, 3. I can turn that, spin that, rotate that around. So there's the aortic valve right there. This is the inside of that valve. There's the 3 leaflets or cusps. These structures right here are those coronary arteries we were looking at before, by the way. Mm-hmm. And this valve, I tell people, looks like a Mercedes-Benz sign. So that's what it looks like when it's closed.
Looks like Mickey Mouse to me.
Or Mickey Mouse, or 3-leaf clover, depends upon one's orientation. This is the cardiac Rorschach test.
All right.
We can also look at that valve when it's open. So we can make sure the valve is opening normally. There's no restrictions or narrowing. So there's the 3 leaflets, 1, 2, and 3, opening normally, so no problems with that heart valve. We also can look at the mitral valve. Now I'm slicing the heart open, and we're slicing right through the left ventricle here. There's the aortic valve seen from below. This structure right here is the mitral valve. Up here is the left atrium.
Wait, I'm not keeping up with you. So this structure you're showing,
right
this
here.
is the blood's moving from here to here?
So the blood,
from here to here, I mean.
Blood is moving down.
Right.
This phase that we're looking at right now is when the heart is relaxing.
Okay.
So this valve, when it's contracting, so this valve is open, and it's pumping the blood out of the heart.
Ah.
This valve right here is closed, so the blood doesn't go back in the reverse direction. This is the left atrium, where all the blood is coming from the lungs. We also can use this to make sure that there's no holes in the heart or anything like that. Here I am taking a peek in the left atrium. We also can look at this structure here called the left atrial appendage, make sure there's no blood clot in there. That can give rise to stroke, so we can look at all that information too. Again, there's the left ventricle. I tell people don't try this at home, please. What I'm going to do now is I'm actually going to cut the heart here. I can rotate and spin around here. We're going to look at both of those valves, cut and cross-section. So this is the mitral valve. We can see that from the top here.
So this is the mitral.
This is the mitral valve,
and there's
the aortic valve we looked at before.
Now that really looks like Mickey Mouse there, see?
It is.
Yeah.
So this is the inside of the heart here. We can look at the mitral valve. This is when the heart's contracting. And then now I'm going to show you when the heart's relaxing. This valve will now be closed, and this valve will now be open as the heart fills and prepares to pump blood again. So there's the mitral valve. We can see that's opening normally, so no restriction or narrowing of that valve. And we can look at that from the top and the bottom. Again, aortic valve here. This is the inside of the aorta, so this is that major 30-millimeter vessel that comes out of the heart, and that's what it looks like on the inside. That little dimple right here is actually the origin of the right coronary artery that we looked at before. So that's the origin of that vessel as it comes off the aorta. And again, there's the left ventricle and the inside of that left ventricle here. We also can go back to the heart. We can take all those blood vessels we were looking at before, the coronary arteries, and we can actually strip those out. And now what we're looking at is just the coronary tree, as we call it. So there's all the blood vessels of the heart. And here's that plaque we were looking at before. We can look on the inside. This is the inside of that plaque.
Looks like a hydra from biology.
Yep. And there's the outside. And note, this stuff is growing in the outside, fortunately for him, because that's how plaque grows.
Wow.
This is a long time. This is, hopefully, I think we got it just in time, but had that plaque begun to grow any further into the blood vessel, that's when he could have had a heart attack.
And if it broke open right here and a blood clot formed, that's just all she wrote.
Right. You're going to lose all of this. See how much part of that heart that blood vessel there supplies. That's a big heart attack, and could even be a fatal heart attack. So we do the coronary tree, yada yada, and that's what it looks like, and we can spin it around. We're going to now, lastly, we can actually take all this information, all this three-dimensional information, put it all back, because before we just pulled the heart out, now we can add everything back. So here what we're looking at is the entire scan. So there's the breastbone here.
Yep.
There's the ribs. There's the heart. We're actually looking through the left lung. I can actually put the lungs back here, and there's your left lung, or I can take that out. There's the spleen here. There's the splenic artery going to the spleen. Here's the aorta coming up out of the heart, heading down to the belly. There's the heart seen from the right side. Again, I can put the right lungs back or remove them. There's the liver right here, stomach. These vessels right here, I always like to point out, that run right behind the breastbone. There's two of them, right here and right here. Those are the ones we use for bypass surgery. And as I tell my patients, of course, we're out to make sure they never need them, but if you ever did need bypass surgery, it's good to know they're standing by, ready, waiting there for you. We can look at your pectoralis muscles. There's your pecs right there. There's your pulmonary artery heading off to the lungs here. And we can also take a look at the trachea. There's your windpipe. So we can actually take a peek right down your windpipe here. So there's your windpipe or your trachea. And when we used to do this invasively, we called this a bronchoscopy to look for tumors and cancers and masses there. Now we can do it all virtually. So this is a virtual bronchoscopy, which we throw in there. And that looks good. No tumors, masses, cancers, no pennies, nickels, batteries, bubble gum. All that looks good. And then lastly, and I call this is now we've entered into the realm of stupid CT tricks. What I'm going to do now is there's the whole scan and the lungs, liver, spleen, all of that. There you are from the bottom. Stomach here, liver. There's the spine, spinal cord, aorta, and the top. Now what I'm going to do for fun is I'm going to put his shirt back on. So there's his shirt right there.
There's the buttons right there.
There you go.
All
so
right.
that's it, Scott.
Voila.
It's the virtual autopsy.
Well, so when you tell somebody that your scan is normal, you've gone through a lot of things for them, haven't you?
When it's normal, it is buck stops here, do not pass go, normal.
And if you have, so when a patient, the process for state-of-the-heart cardiology is a patient comes in, they usually take some pills the night before to get their heart, make sure their heart's going nice and slow. They come in, they get the IV, they walk in, lay down, hold this, boom, 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 come back out, and then you'll either take the time to look at this
just
and
like we did
contact
today.
them,
We
or
do
sit them
exactly
down.
the same thing. We're going to sit down with the patient right then and go through the data right now, right here, because we can actually explore them three-dimensionally with this information. And as I tell people, half of this is useful information for me. Do you have aneurysms, pulmonary embolism, things that you probably couldn't even say or spell? And information for me to guide what's going on, what the problem is, and what we need to do to take care of it. But frankly, the other half of this tool is an amazing communication tool, where I could tell you about aneurysms, pulmonary embolisms, coronary artery disease, plaque, and you'd go, what is this, what's it mean? But when you actually are able to point it out, and I can say, there's a baby plaque, there's atherosclerosis, what do you want to do with it? It's an incredible tool for both communication and motivation and compliance.
It worked on me. I had plaque, took my medicine. I don't have plaque. I'm still taking the medicine because I know if I stop, I'll go right back to where I was.
Right.
So why would I do that? That's nonsensical. Well, John, thank you. What a wonderful tour you've given us, and we sure appreciate the state-of-the-heart cardiology tour of the body. And you have a website, correct? sothcardiology.com.
That's correct.
And people can go see and learn a little bit more about these things there.
Absolutely.
Thanks again.
All right. Thank you, Scott.